Today for the meeting of the New York City Health and Hospitals Medical and Professional Affairs and Information Technology Committee. Today's meeting is officially called to order. For the record, please note that Sally Hernandez Piñero is participating virtually in a listening capacity. So I would like to propose a motion to adopt the minutes of the M&PA Information Technology Committee meeting held on February 5th, 2024. All in favor say yes.
Yes.
Opposed say no. So that the minutes are approved. So we have an action item to consider for the committee, a couple of action items. So I don't know who's presenting it though. Item number 1 in the agenda.
So go ahead. Okay. Good morning, everyone. I'm Jonathan Jimenez. I'm here to request authorization for contracting with 22 community-based organizations for outreach and education. So the NYC CARE program, as you all know, is a healthcare access program that serves anyone who's excluded from health insurance. So that includes folks who are undocumented, but also folks who are underinsured or can't afford insurance for other reasons. And from the beginning, since 2019, we really partner with community-based organizations to make sure that they're building trust in the community, that people feel comfortable coming to us for services, that they're educating people about the program, the mission of the program, the benefits. And really, they've been central to our success. So right now, we have over 135,000 active members. We know from data we gather from the call center that at least a third of the calls that we receive are referred from CBOs and others, family, friends, and facilities. And then what's more is that from the beginning, when we started contracting with them, we tried to focus them on particular zip codes that we knew were high need, high rates of uninsured, low rates of NYC CARE members. And this new round of funding has made us choose new zip codes because we were successful with their partnership in doing that outreach and education. In 2021, we did complete an RFP process. We awarded 22 organizations with an option to renew for another 12 months. And then we did that with 21 of the organizations. That contract expired on October 31st. We did a 6-month extension for the interest of continuity and for time to do this current RFP that we're discussing today. In general, the outreach goals are really, and the funding is proportional to the outreach goals that they're sort of committed to, and I'll go into a little bit more detail about that shortly. But then importantly as well, CBOs are really exempt from MWBE requirements or certification. And so I included this slide to give us an idea of sort of what the spend has been historically. The next slide, yeah. So as you can see, it's been around $2,400,000 per 12-month period, and we try to keep that, as you'll see shortly. Next slide. For the specific RFP criteria, we require that they be 501c3 or that the fiscal sponsor be such. We also require they have $1 million of commercial liability insurance and that they be in business at least for 3 years. When we looked at their experience, what are their substantive evaluation criteria, we looked at their organizational experience, make sure they had a history of that capacity of doing that outreach and education. We also looked at specific experience with the healthcare outreach because healthcare is very complicated. So you need a certain level of experience with health insurance programs. How do you access care? What's most important? Health, cancer screenings, primary care. And we also looked at cultural expertise and humility because, and New York City is so diverse, we wanted to make sure that even if they had expertise in a particular area, that they would feel comfortable reaching out to, for example, we're seeing with new arrivals a lot of WOAF speakers, which hasn't really been institutionalized as an experience yet in some of our big organizations, but we want them to be comfortable doing that and have experience doing outreach to organizations or to communities that they may not have staff that have the same experience. And then lastly, we gave extra points if they had staff that actually do health insurance screening, because that's a part of enrolling in NYC CARE is getting screened for health insurance. Next slide. And so we did issue this RFP in November. We did extensive outreach and had a pre-proposal conference call with 83 different vendors in February. 40 proposals received, which is a big jump actually from last time around, which is great. This is what we wanted. That's why we're doing the RFP, right? And then in March, the evaluation committee selected 22 community-based organizations. Next slide. And so I want to go into a little bit more detail here about how exactly the vendor selection worked. So we looked, as I mentioned, at the substantive criteria, but we also, before the RFP, we looked at zip codes that had high rates of uninsured and low rates of NYC Care membership, with the hunch that those were areas where we wanted our community-based organizations to focus. And so we gave them a menu of options of these zip codes are our priority, and then they chose during the application, the proposal, we could do this outreach in these zip codes. We also really looked for a diversity of experience. And that led to our selections of multi-service organizations that really have experience. We haven't had CBOs in the past that had this similar experiences. So we have organizations now among the 22 selected that have AIDS and HIV service advocacy. Importantly, disability services advocacy. We've never had an organization that specifically served folks with disabilities, so we're really excited about that. And of note, all the selected CBOs really filled all those high priority zip codes. So we think this is a great way forward. And there are 17 CBOs that we've worked with in the past, and they all performed satisfactorily in the past, so we were comfortable re-awarding them this time around. And as I mentioned, and is highlighted in the next slide, the outreach goals and the funding is really proportional to their outreach goals. So, for example, if they have one funding line, they're committing to doing 400 interactions per month, 40 appointments for insurance screening, which of course is a vital process to part of enrolling in NYC Care. And then if they also receive funding for direct enrollment, they'll do 10, committing to 10 per month of those direct enrollments. They also commit to, engaging with us regularly, whether it's to learn about New York City Health and Hospital services, benefits. We have press events regularly, outreach events, days of action. That's all part of their work and their scope of work. The vendor selection here by borough on the next slide. So we have all of the boroughs covered. As I mentioned specifically, they also fill all the high priority zip codes. The staff at these organizations speak over 30 different languages, and they already have track records of serving the zip codes that they chose to do their outreach in. So all in all, we're really excited about this new slate of CBOs and working with them moving forward. And we're looking for authorization from this committee to award these 22 CBOs starting May 1st, 18-month contracts with an option to renew for a total of $6,600,000. But as I mentioned previously, on a 12-month basis, it really doesn't represent an increase, and in fact represents somewhat of a decrease compared to NYC Care spending previously. But the 18-month period, we hope, will give folks longer term to really get to know and be in the community and not have that uncertainty about funding.
Thank you. Any questions from Dr. Martone? Dr. Katz?
Well, I was thinking as the presentation was going that in most communities, they're at best trying to meet the need of people who are arriving at their emergency room. How unique it is that New York City is actually outreaching to try to get people who need care into care. How great that is compared to what's going on in most of the country.
And that we've actually found it extremely helpful too, because as we roll out new services, like we've done a lot of course, expansion of telehealth, we can be out in the community and say, actually Dr. Wilcox was recently presented on women's health services at H&H to all of our CBOs, and we sort of have that with, MyChart, come learn how to use MyChart so you can tell the community how they should be and can be using that. So it's a great partnership.
Great. I have a couple of questions that actually Sally Hernandez Piñero sent to me. So since 2019, it appears that approximately 27,000 members have been enrolled each year, 27,000. So are we able to project how many folks are still eligible to be enrolled in the program, or?
That is a great question, and it's a challenging one to answer because it's very hard to estimate how many people that are ineligible for health insurance. That number and that estimate fluctuates a lot. Early, when the program started, there was an estimate that was 476,000 members with the best methodologies that we have now. And we're actually still working with Moya and Department of Health to see if they can refresh that. And we know a lot of those people are also already engaged in care at FQHCs. So it's really hard to know. From the outset, we set a goal of 100,000. We've surpassed that, and we think there's going to be more because we know some new arrivals will end up being ineligible, likely, for health insurance because of not being able to get through the asylum process.
So the idea is that the other 300,000 get their care through other systems and FQHCs and so on. Is that?
Well, we don't know, and so that's actually our impetus for continuing the outreach work, because we, at least anecdotally, know that some people are still learning about us for the first time. We're still hearing about some stories of people, receiving care for the first time in decades, and so that's our impetus for continuing to do our work without really knowing, could we get to 200,000? I can't be sure, but I know that as of late, and we think, and part of this is due to new arrivals. We have, for example, as I think noted in the slides, we're over 135,000. I should also mention, though, that we're also going to expect a decrease because of the expansion in Medicaid eligibility to undocumented folks who are 65 and over. So over the coming year, we're also going to see a decrease, which is great. That's, we want people to get insurance. We're excited as a part of the re-enrollment process, they'll get screened again and enrolled in Medicaid. But that means they won't be NYC Care members, so it's hard for us to know.
And one more question. So it looks like 400 people are reached each month, and that yields about 40 enrollments, 40 appointments, right? Like the
Estimate per funding line, but we have the 22 vendors represent about 32 funding lines, so it's 32 times 400. That's the amount of contacts that we would be doing per month at a minimum, yeah.
So it's 40 out of 400 then, the total that end up. Is that
Right, exactly. That's sort of like the funnel, yes. And we came up with these outreach goals. These are from 2019 when we were partnering closely with the Mayor's Office of Immigrant Affairs and the Mayor's Fund initially. So it wasn't, we came up with them with them in partnership with them.
Thank you so much. Any other questions or comments? So let me read the resolution. It's authorizing New York City Health and Hospitals Corporation, the system, to execute agreements for NYC Care outreach services to cover all 5 boroughs with vendors, each of the 22 CBOs, and attached hereto as Exhibit A on behalf of the system for an initial period of 18 months with one 18-month renewal option, exercisable at the discretion of the system. These agreements shall not exceed $6,652,800 over the potential 36-month term. And so let me ask committee members for a vote. All in favor, please say yes.
Yes.
Opposed, say no. So resolution approved. Thank you so much, Dr. Jimenez.
Thank you.
And then number 2.
Okay, I'll read the resolution. Authorizing New York City Health and Hospitals Corporation, the system, to execute a best interest renewal agreement with Canon Solutions America Incorporated for the provision of enterprise-wide managed print services for a period of 7 years. The agreement shall not exceed $63,572,940 over the 7-year period. And Jeff Lutz, our CTO, will actually provide the overview.
Good morning. Thank you for the time. So Canon today currently provides all of our printing service support. So that includes consumables like toner, replacement parts to keep the printers working, as well as they are the ones that we lease our large printers. So the fax, copier, printers, scanners, the big devices that you see, we lease, and they maintain all of those across the whole entire enterprise. They were selected from an RFP in 2015. This current contract expires in June of 2024. During that time, so from fiscal year 18 through 24, the total spend was 79 million. Through this partnership with Canon, we've really seen a lot of really good results, and drove a lot of good cost savings and efficiencies within there. Starting with, we've reduced our overall printer fleet from over 26,000 printers down to 17,500. So that's a 30% reduction. That's both in the administrative as well as in the clinical side, where we've worked to implement functions like Secure Print that allow the ability for you can print to any printer and then go scan with your badge and select off only the documents that you want. And we had some programs early on that would automatically just print no matter what. So that was just wasting paper. People were printing, throwing it out. So now we've been able to stop that. They can go in, get what they need, and move on. Same within the clinical side, working closely after visit summary, prescriptions, and the like, and gaining efficiencies in there. And that's helped us both from reducing our overall print volume, so thus we save money in paper and as well as cost on the contract, so toner and the like, so less wear and tear on those printers, as well as we've made the move from going from print color to black and white. So again, saving money in those areas. The other piece that we've done is gain efficiencies in the print fleet as well. So we've gone from fewer models, so over 390 to 234. And what does that mean to us? They're easier to support. Now we can less amount of toner and parts that we have to carry, and we can actually then replace printers and move as we need to in the event that one comes down. And we've also, during that time, which in largely partnership with Epic implementation, have networked most of our printers as well. So again, now they're accessible. They used to be one-to-one, one printer per machine. And if I needed to print to someplace else, I had to go to a different machine. Now they can print multiple places. The last area that we concentrated on was our print hubs. These are our print shops, is what they were called before. We used to have 11, now we're down to 5. They used to support each of the facilities individually, printing out anything from brochures to flyers to different areas that needs within the support the facility. These have now been made more efficient, so they support the whole enterprise. And we've also been able to increase their capabilities, so which allows us to also save money. So they print business cards today. They actually do signage. They were very key during our T2, printing out signage and everything else during that time for wayfinding. So this allowed us again to improve printing and security throughout the enterprise, and we've achieved over 19.4 million in savings during that time frame. Next slide. So since this is a best interest, we went through and wanted to do a review for the due diligence. We worked with Gartner, who we shared the contract with, and they looked at the overall contract, and we talked to them about Canon as a provider of these services, and they gave a good review of Canon as someone providing these services. We also leveraged a group called Conductive through our Geniha contract to do a really deep dive inside of the contract, both from the services provided as well as the pricing. So what they did find is that the pricing was in alignment with other similar sized contracts, both from a size of the fleet that we have as well as within healthcare. And then they looked at some of the things that they did like was our SLAs. We've actually got, as you'll hear, increased better SLAs with this contract. So they meet or exceed what they recommend within these typical contracts. They really liked what we had done with the resources within this contract. We've actually increased our resources while driving down the cost. And that the resources are both project and operational fund focused. So meaning not only are they there to break fix, but they're also engaged. They've got skin in the game to help look at where there's ability to gain efficiencies. We also align to our hard drive, so our destruction, so align to our security practices. Some of the recommendations that they had inside of there were around lease pausing. So in the event that some of these larger devices are no longer needed temporarily, we can actually pause the lease, so not make payments until it comes into function again. And then they also had us talk about price increases. We do have, as you'll see, a way that's a little bit non-traditional, but to mitigate those as well. And just quickly about Conductive, again, they came from Jiniha. They've got 20+ years of experience in doing these types of marketing insights and comparisons. Their pricing that they balanced, that they compared this against, includes not only Canon, but so we can see what they're comparing against other customers, as well as their major competitors, so your Xerox, Staples, Ricoh, and Konica Minolta within there. So it's a pretty good benchmark inside of that. Next slide, please.
And our SLA is a service line agreement, just,
Yeah, sorry, the service line agreement. So our response time to service those printers. Thank you, Kim. The reason for the best interest renewal, as you can imagine, with this being a very large and complex environment, over 17,000 printers, and they actually have they have a team that sits on our service desk. It's people that are deployed there. This would be very difficult for us to transition. We would and as well as seeing that we get better SLAs. We also have lower costs within this contract, and based on the pricing due diligence and everything that was in there, there wasn't a significant gain that we would gather. In fact, we probably would sacrifice a lot of the cost savings in order to make that transition and incurring higher costs within there. And it took us years to bring Canon as well, for them to learn us as well as us to learn them, and really gain a lot of these efficiencies that are inside of here. So based on that, we decided to move forward with a best interest renewal. Next slide, please. As you've heard, their vendor performance, they perform satisfactorily across all areas. Slide. So with the new contract, we are looking for a not to exceed of $63,572,940. They have a annual gain share or max spend. So this is where we deal with price increases. So over the contract, we will save $16 million. So what you see in the bottom there is not only the year in and year out, but that's their max contract, the max amount that they can spend with us. So they have skin in the game. So as you see, we drive down costs every year associated with this. So this is how we price protect ourselves as well. Aside from the lower prices, we actually are going to gain resources. We've worked with Canon to help right size based on our experience of what we've seen. And we've also worked with them to create a quality assurance team that allows us to go from facility to facility and help spread. One of the challenges that we have today is we make some really good improvements at one facility, but we don't do a good job of moving those across the whole enterprise. This team is going to help us to do that, as well as compare each of the teams across the facilities as well to gain efficiencies where one might be doing something a little bit better at one facility, and how can we spread that to the other ones. So provide some real better visibility into that. The next part is our service level agreements are now better within there, so there's a faster response time as well as a faster time to repairs. And this is based on what we've seen out of the tickets and everything else from ServiceNow. So these are realistic in what we can. And we also get a 5% credit in the event that these SLAs are not met. And then the last part is our multifunction devices. They're on 5-year leases. After the 5th year, they actually get reduced by 25%. But you won't see, because it's going to take us a couple years to replace out, it's about 2,700 printers that we will have to you won't see that drastic 25% jump or after year 5 or drop. It's going to be progressive as we replace those. So next slide, please. So as part of the diversity, that in the past, well, they lease Canon leases these through a MWBE Garrick. Last time they were able to achieve 14.5%. We've challenged them to go to 20%. We're confident we can get there with them on this. They will continue to use Garrick within the for their subcontractor for the leasing. And part of this as well is that, as you can imagine, the lease rate will stay essentially the same across that time. Where we gain the cost efficiency is in the resources as well as reducing our print environment in the areas that are not the multifunction areas. So that cost is going to stay proportionally the same, but our overall cost comes down on those sides. Next slide. So in summary, today we are seeking to enter into a 7-year contract with Canon Solutions America for managed print services at a not to exceed of $63,572,940 to support and maintain our print fleet, purchase print consumables, and provide resources to support the printing and establish a more efficient print environment, support and drive efficiencies throughout the New York City Health and Hospitals print hubs. We do have the ability to terminate for convenience, and again, the term is 7 years.
Thank you. Any questions from committee members? Dr. Martone, Dr. Katz?
I have a question, Jeff. I think it's a great presentation, and I totally agree with both the process you used to determine that we should continue with Canon and the overall goals of the contract. So my question is a little bit to the side, which is we've decreased from your presentation from 400 million pages printed to about 200 million. If we wanted to have a plan to go from 200 million to 100 million as an organization, how would we do that? How would we, or who would, right? I mean, the world is trying for good reason, and we should try for good reason to print less, right? It saves money. It's good for the environment. It often protects confidentiality because you don't have paper flowing around. We've made an impressive drop. I think that the things that you've put in created that drop. I think especially the having to card into the machines. But I don't know that we really have, and not to say necessarily it's your job, but say that it should be the job of the health and hospitals. I don't know that we have a plan about how we would go from 200 million pages printed to 100 million pages printed.
It's a great question, and yeah, there's still opportunity that's out there. I guess we do have what we call like an unprint initiative. So you'll see varying. We actually have little videos and different types of things of how, like, a lot of people save their emails or save different, how to do it in an electronic format as opposed to printing it and putting it into a file cabinet. Within our Canon team and led as well from our side, Ishmael Miller, we have a lot of visibility into those areas. I think one area, to your point, we could do a better job is really pushing that out and advertising this a bit more, and then looking for feedback. That's also part of what we've developed, this, lack of a better term, quality assurance team, to look for those types of opportunities as well, and to really engage and provide much more visibility into the organization to change their thinking around these devices and the opportunities that present themselves there to really drive these types of efficiencies.
One idea would be to do more like what you do with Epic, which is to give individuals who are using it elbow support at the time that after they use it. So what I'm thinking is, you have the data, you know where we're printing things. My guess is that you'd have to go to the place where stuff is being printed and say, here's another way that you could do this, right? Because the people who you're advertising to, they already don't want to do it because they've been doing it a particular way, right? And I don't think even the best placed commercial is going to do it. I think, but again, I don't want, it isn't your team's job necessarily to do this. I just think that as an organization, we should do this. And I'm trying to think about, what would be, right, the intelligence that you have is where things are being printed. Right, so which is good because often when you're trying to solve a problem, you don't know the scope of the problem. Right. In your case, you to the page probably can tell us the scope of the problem. You could tell us where the 2 million pages, the 200 million pages are being printed. Right. So we have a phenomenal view of what the issue is. And then the question is, where are the best opportunities to drop that, and how would we do it? I mean, we print a ton for our patients, which is good. I mean, that is a major epic thing, right? Is everybody leaves. We don't ask people if they want it. Right. So if you were on a MyChart, right, then you don't really need it.
Right.
We don't say, would you like us to print out your summary? We just hand you your summary. I suppose, we could say, would you like your summary printed out, or would you like to look at your summary on MyChart? I don't have a particular, usually because of my clinical work, I have a sense, but because that sort of happens after I see people,
Right.
I don't really have a sense of how useful the printed summaries are to people. Do you?
Dr. Katz, we agree with you. And we've actually partnered with quality and legal on this. And we're trying to digitalize a lot of our consents and signature work. So in the emergency department and inpatient, we require a patient's signature on the discharge paperwork, the AVS, after visit summary. There's nothing, we can digitalize that. That is a body of work that we are doing now. And then if the patient has MyChart, which is for our primary care population, upwards of 80%, we don't need to print it. So that is one leg of the body of work that you're talking about here.
So I guess, and I'll think about it afterward, but maybe you can start thinking. If we wanted to say, and I'll charge Kim and she can bring it, to the group of the SVPs. Because again, I don't want to say this is your problem to own necessarily. That it seems like at this moment in time, we as an organization should have a goal that over the next 5 years, we're going to reduce the amount that we're printing. And then we should charge some set of people with achieving that goal, right? And, they should use your data to figure out where the problem is. And you could also use your data to see, are some offices for their size printing more than other offices? Right, so, the old, look for variation, just as we do in clinical work, and then try to bring everybody to the middle. But I think that would be worth doing, and it fits our times, it fits our goals. Is that a fair goal? Again, not to burden your group necessarily with the job of doing it, but let's have a plan. That's specific to how we're going to achieve this.
Sure.
An unprint challenge.
An unprint, well, it should have, a 5-year, year-by-year goal of how many decreased pages and what we're going to do and everybody's, interest in doing it.
Got it.
Yeah.
I mean, we could ask ourselves, I suppose, if we want to be good stewards, right? If we're going to have presentations, do we want the paper? It's worth asking, right? Maybe we don't want the paper. Or maybe some of us want the paper, and they should get the paper, and some of us don't want the paper, and want to watch the screen, so we should save it. I mean, again, Right, we have to respect that there are differences in learning styles, and right, the point isn't to, force people, the point is to enable people.
Yeah, agreed. Takes a village. No, I appreciate it.
Dr. Marton?
I am not a piggybacker, but I'm going to piggyback on this conversation because I really think it's so important. I heard high utilization rates, look for the high utilizer. I heard, do we have a sustainability officer? Because maybe that's what we need, somebody to do the wraparound on this issue. And then when you were talking about the ED discharges, I would think that the repeat offender of never going into my chart would be somebody who has never been able to access it. And maybe part of that program would be to add a component where somebody actually signs them in, right, on that discharge and say, here's your paperwork, right? So that moving forward, they have it there. So just those little things I think could bring us a long way. Very, very big on keeping it green, and I think we could do a lot with that. Thank you for your presentation.
Thank you.
Okay, so let's take a vote on this. All in favor, please say yes.
Yes.
Opposed, say no. Resolution approved. Thank you so much. So let's move on to the Chief Medical Officer's report.
So let me start it off. You can start with me, Kim. I'm probably responsible for 200 million of your 400 million.
We'll be over to your office.
Okay. So what we've been doing with the MMPA presentations here is highlighting some of the work that's being done throughout MMPA. And just to give you a sample of the work that's being done, Dr. Techie is developing our system-wide cancer services. Dr. Bell has been establishing new residency programs at South Brooklyn Health. They have a new anesthesia residency and a new surgery residency. And Jacoby has a new OBGYN residency. Ashwin Basavaraja is working with low-dose CT lung cancer screening. Rajesh Verma is working on staffing models on the inpatient side. Manish Parikh, robotic expansion, increasing OR efficiency. Michael Megadushian is working with simulation. Omar Fatal, he's meeting the needs of the behavioral health crises in New York City, just everything. And this morning, Dr. Wendy Wilcox will be discussing the work that she's doing with women's health, which actually focuses on our pillars of patient safety and quality and outcomes. So Dr. Wilcox is our Chief Women's Health Officer for the enterprise. Wendy.
Thank you, Dr. Allen, and good morning. Thank you for this opportunity to present some of the work that we're doing. I've been in my role about 2.5 years, so that's how long the office has been. I'm really proud of the team that we're building, and they're really passionate, as am I, and we've been up to a lot of things. So this is just a high-level view of some of the work that we've been up to. The Office of Women's Health aligns, of course, with the mission and vision of New York City Health and Hospitals. And as Dr. Allen mentioned, this morning I'm going to focus on quality and outcomes, some of the work we're doing in care experience, and culture of safety. Next slide, please. So really, because I was new to the role, and the role was, I'm the inaugural Chief Women's Health Officer, and in my purview is our 11 departments of obstetrics and gynecology, and we knew we have some very high functioning departments and some maybe that needed a little work. I needed to fully, as also Dr. Allen needed to fully understand where all of our departments stood. Our professional organization is the American College of Obstetricians and Gynecologists, also known as ACOG, and ACOG provides a voluntary review of quality of care. It is a program that they have been running for since 1986. They have conducted at the time, over 230 site visits all over the country. It's staffed with board-certified obstetricians, gynecologists, nursing, as well as, if you request, midwives and anesthesiologists who will come in at your request, meet with the teams, review charts, interview people, look at policies, and really give a sense of the overall functioning of your team, of, your OBGYN team. They come in on a Thursday evening, they have an entrance interview, and then the exit interview is 8 a.m. on Sunday morning. They give a verbal report, and then usually about 2 months afterwards, we receive a written report. So starting in April 2022 and ending in March 2023, which was just last month, ACOG VRQC conducted 11 site visits of all of our OBGYN departments. To date, we've received 9 of those reports. I am currently working on a complete assessment. However, I will need to receive 11 reports before I can fully do that. However, not to wait until we receive the last report, we've already been working on some items that have really risen to the top. I will start with the positive. Across the board, our ACOG VQRC teams have noted that our staff, and we know this, is extremely committed to the patient population and the communities which we serve. In fact, at our very last review, the lead reviewer was so moved that she actually quoted Dr. Martin Luther King in her exit interview. She was that impressed with the team. Now, on to some opportunities that we have to improve. So one of the most commonly cited opportunities is that all staff, our physicians, nurses, midwives, and residents, need training in fetal heart rate interpretation. With Dr. Sineas and Tiffany Johnson, who's on her team and my team, we've started AWHONN training. AWHONN is the Association of Women's Health, Obstetric, and Neonatal Nurses. They are the industry leaders in fetal heart rate training. It is nurse-led training. It is in-person training. And so what Tiffany and Alex Gingerella, who's on my team, have done is helped our sites to get organized into groups. We have brought in AWHONN certified trainers, and at each facility, they've held multiple trainings so that staff can both engage as a team as well as learn fetal heart rate training. To date, they've completed 2 facilities, and this is pretty impressive since they really just started in January, and the rest of the sites are ongoing. Another finding is that we need a more robust quality structure that really should be developed at the system level and then reach down into each department. I'm currently working with Hilary Jalon and Dr. Agway to establish that, as well as we, by New York State's statutes, really also report to our regional perinatal center, that is Bellevue, and so Dr. Judith Cervenak is also involved in establishing this structure. ACOG felt that we needed a more formal peer review structure, and so working as leaders in the OBGYN departments, as well as with the Department of Quality to establish that. Really, they felt that team training was needed to enhance communication and foster healthy developmental culture. That is encompassed in our AWHONN training as well as in our simulation training. And lastly, the need for not just updated policies that are system-wide, but also on a apology management system so that they're easy to find for all comers and that it will alert us as to when they need to be revised. In terms of care experience, this is really exciting. We've partnered with our virtual Express Care team, and for postpartum women, they will be able to access a provider 24/7. This isn't just for clinical postpartum concerns. This also includes behavioral health concerns. And so we all know, or you may or may not know, but the postpartum period is a really vulnerable period for women, especially when it comes to maternal mortality and severe maternal morbidity. Almost half of all deaths from maternal mortality occur in the postpartum period, up to 1 year postpartum. And so this has already been launched, but we're really going to go big in terms of it will be on everyone's discharge summary in terms of maybe printed, maybe not, after the last discussion, in terms of how to access this number, and it will be open to all comers. And then, of course, the regular triage that they do. Maybe someone needs to go to the hospital. Maybe they just need to talk to someone about their baby. You know, maybe they need an urgent visit, and all of those options will be available. Now we're going to talk about something that will lead to the next slide in terms of quantification of blood loss. So being able to quantify how much blood someone has lost after either a vaginal delivery or a C-section is really important to get a handle on whether or not someone is experiencing a hemorrhage. And to date, we really have not had a very good way of doing that. Please imagine someone taking wet laps soaked with blood, maybe amniotic fluid, and either trying to weigh that or otherwise estimate how much blood someone has lost. It's a very imprecise process. It was very labor intensive, and it was not standardized. So, and actually this is something that is recommended not only through ACOG, but also Joint Commission. So we really needed to have direct measurement of obstetric blood loss and have it standardized across our system. Next slide, please. So Triton QBL, Quantitative Blood Loss System, is a system that enables us to do this. It really is quite novel. It uses light technology, and it scans our laps, as well as has a reader in a canister that can determine how much blood is in there, even if it's mixed with amniotic fluid, because it senses the darkness of the color and then assigns a quantity to that. As of March 2024, all of our labor and delivery units in 11 hospitals have had it implemented. And so we are getting ready for the assessment of that, but we are really excited that has happened. The interesting thing is the nurses are incredibly positive. They're very excited. It obviously has made their job easier, especially in the OR. Our physicians are a little, they've been used to underestimating blood loss. And so sometimes when you get a machine that tells you a number that's a little bit higher, it makes you a little uncomfortable. Talking to other sites that have implemented this, meaning across the country, this is a normal response, and you know, we will manage that. Next up on the list is our PeriWatch fetal monitoring system. Our OBGYN council really did quite a rigorous review. We took about a year, believe it or not, to examine all of the fetal heart rate monitoring systems. Fetal heart rate monitor is a monitor that senses the baby's heartbeat and gives a readout, which we then as providers interpret. And we sensed that our providers needed some more decision support help with that, as well as our current system was becoming outdated. So after taking this rigorous review, our providers settled on something called PeriWatch Fetal Heart Rate Monitoring System. It's a PeriWatch Vigilance Fetal Monitoring System. It does use AI capability to help providers, especially in the Category 2 tracing, which is kind of an indeterminate tracing, and it may be hard to figure out whether a baby is in danger or not. It allows for standardized documentation and greater ease of documentation, especially for nursing. And it will take about a year to not only put the hardware necessary for this implementation, but also to put in the rules for the decision support, which will be specific to health and hospitals. And that is just an example of some of the things we're up to. So thank you for this opportunity.
Thank you. Any questions or comments?
I just want to say that Triton is awesome. Thank you. That's a great change for us.
On the voluntary review, that was very interesting. Do they come in and then when they provide recommendations, are they based on what the team knows or what they have learned from visiting so many other facilities around the country, and they say
it's
here's
both.
things you need to do?
It's both. It's a really comprehensive report. They actually give you references. If they bring up something and they think that the reference will help you, they'll say, we think you should look at this to get this example. They will actually say, yes, we've visited many sites. You know, you're not the only one struggling with this. or, other sites have done X. Maybe you should think
So
about that.
It's very
So
constructive.
it is constructive. The reports are about 25, 30 pages, most of them. They're very dense, but there's a lot of information in there. We've been taking them, as have the teams, and as I said, implementing what they've found.
And they're practitioners themselves, so they actually know what they're talking about.
I think it's so nice. I've read all of them. I thought they were very helpful. It's also in some ways positive that it's peer and voluntary. Right, so you don't have the defensiveness that most sort of joint commission or other, right? You have to invite them.
Yeah.
Right, and you're inviting them because you believe they're going to be helpful to you, right? And so I think in general, it's a better model in some ways of how do you improve an organization.
Sounds very interesting. So thank you so much.
Thank you.
So let me move on to Dr. Cineas, Chief Nursing Officer report.
Good morning. Okay, good morning. So we've completed Bellevue Hospital for the care delivery model, which is implemented to improve communication and to standardize the nursing process and standard of care. We have 4 more hospitals that remain for 2024, which will be Jacoby next in June, Kings County in September, Woodhull and NCB in Q4 of 2024. Next slide, please. Leadership visibility continues with CNE town halls for leadership and also fireside chats for frontline staff. Most recently, in March, the town hall focused on the clinical ladder program, which is a partnership program with NISNA. We're pleased to announce the rollout of a new cloud-based system by the name of Staff Garden, and thank you to the IT team, Kim and her team. We rolled out 2 new platforms in a month. It's been a lot of hard work, but it's been phenomenal. For Staff Garden, we have over 900 nurses that have already applied for the clinical ladder program. The goal is to exceed 1,300 from last year. Next slide, please. So I mentioned the fireside chat as well. We focused on the clinical ladder program to ensure that the nurses understood when training would take place for the new cloud-based system called Staff Garden. And again, pleased to announce that over 900 nurses have already applied in less than 3 weeks. Next slide. We continue to have excellent recognition throughout our critical care units across the enterprise. Most recently, Jacoby Cardiac Cath Lab Gold Beacon Level, which is one of only 4 cath labs in New York State and 1 in 7 in the country. Neonatal Intensive Care Unit at Metropolitan received Gold Level Beacon Award for Nursing Excellence, the first in New York City and the second in New York State. Next slide, please. Kings County's Neonatal Intensive Care Unit received Silver Level Beacon Award for Excellence, and Jacoby's NICU also received the Silver Level Beacon Award for Excellence. Very excited that Jacoby received a Silver Level Beacon Award for Excellence, one of 4 CCUs in New York State at Jacoby. So a lot of great work happening within nursing, within critical care. Within the Nursing Clinical Ladder Program, as I mentioned, Staff Garden has rolled out a lot of participation. From a certification perspective, we also rolled out, next slide, a new cloud-based system. The goal was to have 1,000 nurses register for this new system within a year. We've had 956 within 3 weeks. So the participation and engagement of our nurses is simply phenomenal when it comes to professional development. We're really excited to see so many nurses want to become certified. We also held a system-wide Certified Nurses Day celebration on March 28th, and we'll be celebrating the top 3 facilities, Queens, Elmhurst, and Capitola, for in-person certification events this month. Lastly, right now, recruitment is our top priority, and so we've established a number of critical care fellowship programs, starting with the emergency department to recruit new nurses. I'm pleased to announce that we're projecting 300 graduates from this new fellowship program for the emergency department, and we will be rolling out a critical care fellowship, an OR fellowship, and a neonatal intensive care unit fellowship in the next 3 months. This is imperative to ensuring that we are hiring new graduate nurses in critical care settings so that they begin their practice safely and understand the nuts and bolts of critical care nursing. That concludes my report. Thank you.
Thank you so much. Any questions from,
Dr. Sunus,
Comments,
as always,
just-
excellent report. Thank you.
and congratulations to, I guess, all of us on the Beacon Awards and all the gold and silver, Metropolitan
Excited.
Gold, all the other ones silver. Excellent. Okay, so let
And
me
she's
move
so
on.
far ahead in her hiring plan.
Yes, yes, that's, yeah.
Really impressive.
So, Chief Information Officer report, Dr. Mendez.
Right, so in our report, we have outlined our 2024 goals and where we are with our objectives and key results. Today, we're going to focus in on two key areas, one clinical information and one with the EPIC module. Dr. Boughton leads both of those areas, and we'll do a very streamlined update on those two modules. Mike?
Great, thank you so much. The first, you can go to the next slide. The first one we're going to talk about is the EPIC transfer module that we successfully implemented. There's two kind of important things about this. The overall project is we wanted to keep our clinical staff inside of EPIC, so they're not having to go make phone calls. We want to keep it all inside to really streamline the operations. This does that. So if you want to initiate a transfer, you place a transfer order inside of the electronic medical record today. Goes to the transfer center center works it inside of EPIC, and then they connect the clinical teams via something called secure chat. Think of it as like text messaging within the electronic medical record. That's something we implemented about 2 years ago. It's a very high level of adoption within our system, and that's really what makes this project work and what really cut down on the number of phone calls. We are really moving towards a platform strategy. The more functionality we do within the electronic medical record, the easier it is for the provider. Everything just kind of works well together, and this module was one of the reasons it was so successful is that we had that in place previously. The other part I want to attract your attention to is kind of what you're seeing on this screen. It's our process. We go through a process whenever we implement something that is new. Now, the first step of it is to have a good design. And a good design really means partnership with the end users. So the clinical teams, the business applications, whoever the other folks are that are actually going to be using that process need to be involved up front at the design part. We always do that. A good design makes for a good build. That's where the analyst team goes through and actually builds it out. A good build makes for a good test. We do rigorous testing before we go live with anything. I won't go through all the details, they're in the slides, but it's many different types of testing we go through, including end user acceptance testing to make sure it's working the way they think it should be working prior to go live. A good test makes for a good train, and a good train makes for a good go live. And that's what we've seen here on this transfer module. We had a very successful go live. Minimal issues. There's always some that come up, and we can troubleshoot those. But we have transitioned. I think a couple weeks in, we had already done like 400 plus transfers within it. It was pretty much a seamless transition. We're very excited about that. The other module I wanted to talk about is Nuvolo. That is our computerized maintenance management system. So basically what that is, it's a database of all of our biomedical devices. We wanted the ability to go to one spot that we had control over so we could look at our devices, understand what needs to be updated, what is attached to what server in case there's an issue, and have full control over that. Nicely, and this interacts well with what you heard earlier about the platform strategy, it connects with ServiceNow, which we've already been using. So when a user has an issue, they place a ticket to our enterprise service desk, and it goes through a process and it's all connected. So ServiceNow is connected to Nuvolo. So we are trying to create a seamless experience for our end users in both of these cases. And that's it for these two.
Yeah, and I just want to highlight with the Nuvolo, one of the driving deliverables on that is that we are able to then look to see if there are any legacy issues from a security perspective with any of the biomedical devices, which is really a key area for us. And this system allows us to do that and allows us to prioritize those for remediation.
Thank you for your report. Any questions? Okay. And then we have
Metro Plus
one more,
Health.
Metro Plus.
Dr. Shah.
Thank you. On behalf of Dr. Schwartz, I see Kalicia jumping up and down in her chair a little bit. I'm getting various signals from Dr. Pagan, so I'll be very brief. Only to say that it's always welcome news to announce that more expansion of insurance coverage for folks. So the essential plan, which currently has a federal poverty limit of 200, is now being increased through a state innovation waiver to 250% of the FPL. That means more people will get coverage, and particularly individuals currently covered through the qualified health plans who have to then pay a premium, that you get premium relief as a result of this FPL expansion. MetroPlus estimates over 3,400 of our QHP members will be positively impacted by this provision, and we will be moved to the EP 200 to 250 plan. That's the current name for it. It will be the savings, as you can see at the bottom of this slide, on average of about $4,700 per year compared to what they would have paid, or we would have paid through tax credits in the QHP plans. Stop there. I can keep going, but I can stop there if you wish.
I don't think anybody's going to object to you stopping there, given the time. Could you, at a future meeting, discuss what it would take to broaden MetroPlus Health to the metropolitan area? It's something that comes up all of the time. And I know people who, really want to be members, who live in Westchester, who live in Long Island, who live in New Jersey. I know it takes effort.
Yes.
You can't just turn it on. But I think it'd be worth the board hearing, a little bit about what would the effort be, what would the gain be, so that we could be involved in the decision of, doing it. I mean, it might be best to first do it with your own MetroPlus Health Board, but
Yes.
it's an issue that people raise to me all the time.
Yeah, we've reviewed it, Dr. Katz, at the most recent board meeting as one of our 2024 strategic pillars into 25 and 26 about geographic expansion. And certainly, once it evolves a little bit more and matures in terms of a more concrete plan, we can certainly bring it here for
That'd be
discussion.
great. Thank you.
Sure.
Is there any old or new business to come before this committee? Then committee meeting adjourned. Thank you so much.
Thank you.
Why do you always say, is there?
This meeting